and the team for inviting me to speak this morning. I was done this morning, this afternoon. It's so important that we consider women today, and I know that this presentation topic might be a little bit different, but of course the population is 51% women, and of course we know that the conditions that we're talking about, osteoporosis and fragility fractures, will negatively impact women more than men. So we need to think about a life course approach when we think about prevention of bone fractures in postmenopausal women. And that's why my talk is more about the pre-menopause, the menopause, and the postmenopause. I'll be covering a little bit around menopause itself for those of you who may not be as familiar with it, some of those risk factors, bone health across the life course, prevention, and then with more of a focus on hormone replacement therapy. Because I think we'll agree that over the last 5 years, social media has erupted with people's experience of HRT, of testosterone, and how this has impacted their menopausal health. With no little thanks probably to Davina McCall, who's driven prescribing and HRT sales. So what is the menopause? It will be inevitable for 51% of the population, and it's a retrospective diagnosis, and that's the difficult thing often for women. You need to have stopped your periods for at least 12 months, and the average age of this in the UK is 51 years. But of course there's the bit that comes before, the perimenopause, when we go on a roller coaster ride of hormone fluctuations, when symptoms come out of the blue with very little warning. And we have the physical symptoms, the vasomotor symptoms, the flushes, the sweats, the poor sleep. But we also have the psychological symptoms, the emotional lability, feeling like we never know what's going to happen from day to day. And the SWAN study is a very interesting cohort longitudinal study in the United States that's following over 3,000 women from different ethnic backgrounds to show how menopause impacts people from different ethnicities. So why does it matter? Well, 80 to 90% of women will experience menopausal symptoms, but their symptoms will be unique to them in many ways, and how they experience them and how that impacts on their quality of life. On average, symptoms will last for around 4 years, but there's a percentage of women where it may go on for much, much longer, perhaps 10 years, 15 years, 20 years. And of course, this has far-reaching effects on their relationships, on their ability to hold down a job. And if we put that into context here in Wales, we know that 13% of the population is around that 45 to 55 age group. Women make up 71% of the part-time workforce in Wales and 82% of the social care workforce. And of course, added to this risk that we know that 1 in 2 women over 50 will experience an osteoporotic fracture. So menopause has a significant impact not only on the individual, but on us as an economic society as well. We need healthy women to keep this country ticking. And menopause has a systems-wide effect. This lack of estrogen is going to have effects on the brain, and on the heart, and on the bones. We know that women are living longer, around just over 82 years. But we know that they're living for over 2 decades in poor quality of life. And the menopause age isn't changing. So women are going to be living 30, 40, 50 years without that estrogen within their bodies, which is helping to maintain their bones. And there's a lack of understanding. A YouGov survey showed that 41% of women had never considered that they may one day be diagnosed with osteoporosis. Menopause and the time leading up to it represents a major opportunity to raise awareness and intervene early. Peak bone mass, as we know, will only be reached round about the 30s. And then that bone density gradually declines. But at the menopause, that loss accelerates significantly due to that lack of estrogen production, which increases osteoclast activity and bone resorption. Data shows that women can lose 2 to 5% of infertility in those first few years after the menopause. It's a time of rapid bone loss. And of course we know that there are modifiable risk factors, and we've just heard about the importance of doing that risk assessment. And that's something that we've brought into our clinics in our specialist menopause service, talking about smoking cessation, talking about reduction in alcohol, thinking about BMI, nutrition and inactivity. We want to support women in that period leading up to the menopause to optimise their peak bone mass. So there is things that we can do about it, and it's about having those opportunities in our clinical spaces to be able to discuss them with women. And I think we heard very significantly in one of those first videos around there are multiple opportunities that we can actually have these conversations with the women in our lives and as clinicians that we meet in our consultations. It's having those discussions perhaps with the adolescents around perhaps menstrual disorders. It's having conversations around contraception and talking about appropriate contraceptions to people with different risk factors. It's thinking about the impact on pregnancy and breastfeeding. And of course, premature ovarian insufficiency, so important that we have those conversations around bone health. It affects around about 1% of the population, but we know that in terms of it having those long-term morbidity and mortality outcomes, it's devastating. It's not just around that inability of fertility, it's around cardiovascular disease, it's around bone health. And then of course breast cancer. The person who spoke in the video talked about their cancer experiences, these life-saving drugs that unfortunately also can have devastating effect in terms of early menopause. And then of course the postmenopausal osteoporosis risk. So what can we do? Thinking about prevention, I think the first and foremost thing that we need to do is thinking about building the bank, building the bone bank. And that's thinking about how we can use those opportunities leading up to the menopause to have these positive conversations with people. Thinking about education. Here in Wales, we've just launched the first women's health website for Wales, where there's information, there's signposting, there's opportunities for you to be able to send people to that site to find out more information. It's about being more Sally Gunnell, and what do I mean by that? It's about making exercise relevant. There's probably few people in the room who want to go out and have a run, or go out and do some weight exercises. But what Sally Gunnell talks about is doing dumbbell lifts so that you can lift your grandchildren, or doing a leg lunge so that you can actually get up and down the stairs. It's about making exercise relevant. It's about talking about appropriate calcium and vitamin D. And whenever I do the calcium calculator with patients in my clinic, they're always amazed about perhaps the lack of calcium that they have in their diets. It's adding in vitamin D and it's having those smoking cessation conversations. So making it relevant, talking about what it is that maintaining healthy bones will mean for that person in the future, for them, and what matters to them. It's about slowing the loss. So thinking about the perimenopause, thinking about from the years of probably 45 to 55, when those hormones are changing. We've had this opportunity with social media and with priority cases who are talking about their menopause experiences, is encouraging women to come into our clinics. So let's capitalise on that. Because actually what we know from data is the time probably leading up to that last year before periods cease altogether, that actually that is the greatest loss of bone density. So let's use these opportunities when women are coming in talking about their flushes and their sweats to ask around bone risk and bone health. And it's signposting them to appropriate information. There is so much at the moment on social media about menopause, about collagen, about what we can do to keep ourselves young, fit and healthy. But it's so important that we have evidence-based information that we can signpost women to. Here in Wales, we launched the first Women's Health Plan back in 2024 with 8 priority areas. One of them is around menopause, but one of them is about living well. And I think these two have to come together because the menopause is a priority. We need to make sure that we raise awareness about this key part in a woman's life, but it's also thinking about bringing that through to the cardiovascular disease and the bone health to make sure that they live long and well. It's doing that FRAX assessment. It's thinking about who needs to have the DEXA scan. And I know that there's been improvements in those waiting lists for DEXA, certainly locally. It's thinking about treatment, and we're going to come on to thinking a little bit here about hormone replacement therapy. So let's have a look at HRT. I think we've come a long journey in terms of prescribing HRT from perhaps 20, 30 years ago from GPs who are in the room who will remember those scares around HRT. And the WHI and the Million Women study that basically stopped women using HRT overnight. But it's so important because we know that that reduction in estrogen is going to have that effect on bones. And there's this window of opportunity that we think below the age of 60 and within 10 years of the menopause that we can actually give HRT quite safely. The benefits outweigh those risks. And in terms of what we have to prescribe, prescribing data has actually shown that predominantly women are now prescribed a transdermal estrogen, so it misses out the liver and first-pass metabolism, it doesn't increase that risk of blood clots, and we prescribe body-identical progesterone, which is much safer than those synthetic progestogens or oral treatments that we've previously used. It should absolutely be given to women who have premature ovarian insufficiency, probably until the age of 51. It should be given first line for those who have perimenopausal symptoms and fracture risk, and that's in the updated NOG guidelines. And it should be given to women who are symptomatic, who are requesting HRT. And of course, we want to increase access to HRT and to HRT clinicians here in this country. HRT prescribing by those who have gone through training courses is actually very simple. Estrogen is the predominant hormone that we're replacing, and then for those who have a uterus, we're adding in, as I said, progestogens. In terms of the dose that you should be prescribing, there was previous discussions that perhaps a 2 milligram estradiol dose or a 50 microgram patch was probably what was required, but even low doses are now suggested to be enough for adequate protection for bones. As I said, transdermal is predominantly what we prescribe now, and that's because it's a lot safer, so more women can use it. And it's making sure that we add in the calcium and the vitamin D where appropriate. And there's no arbitrary age limit for HRT. It's more about taking that individual in front of you, reviewing their risk factors, and supporting them to have HRT for as long as they wish to use it, whether that's into their 60s, 70s, 80s. So my take-home messages this morning are that bone loss starts well before the menopause. I think the menopause is a key opportunity that we can intervene, but let's have those life course discussions. Menopause obviously accelerates the loss dramatically of bones, and that's due to that lack of estrogen. And it's so important that we have those discussions around exercise and nutrition, where appropriate we can prescribe HRT, but it's important that we do identify those high-risk women and that we can appropriately signpost and refer to our fracture liaison services when needed.